Good afternoon. I'm Dr. Eric Toring. I'm the Senior Vice President for the American College of Veterinary Preventive Medicine, and I want to welcome you to today's webinar. The webinar is sponsored by the American College of Veterinary Preventive Medicine and its sponsor organizations. I should have said partner organizations, not sponsor organizations. I apologize. Our partners, the National Association of Federal Veterinarians, the American Association of Food Safety and Public Health Veterinarians, the U.S. Animal Health Association, and the American Association of State Public Health Veterinarians. I would like to right now turn it over to Dr. Heather Sringanathan, who is the chair of the ACVPM Continuing Education Committee. Heather?
Hello. I will do a quick plug for the CE committee. So if you have any suggestions for webinars, please feel free to send them our way. And then I would like to introduce Lieutenant Commander Dr. Tori Moore. She served as the veterinary medical officer in the rickettsial zoonosis branch of the CDC. Oh, she serves, sorry. She previously served as the CDC Epidemic Intelligence Service Officer at the South Carolina Department of Public Health, where she was a disease detective investigating outbreaks of illness and injury across the state. She worked in large animal clinical practice and for USDA FSIS prior to her role at CDC. She attended veterinary school at the University of Georgia and received her master's in public health from the University of Missouri. She is board certified in veterinary preventative medicine, and she is passionate about integrating clinical veterinary skills with expertise as a public health leader and epidemiologist to improve the health and wellness of people and animals. So thank you, Dr. Moore. I will hand it over to you.
Thank you so much, Heather. I am glad to be here. And thank you all for spending a part of your evening with me to learn more about Rocky Mountain spotted fever and about our cool national survey findings that we recently came out with. So I'll begin our chat today with a clinical overview of Rocky Mountain spotted fever. We'll talk about dogs mostly, but I will give you a little insight into the human disease as well, just so you're aware. We'll dive into the traditional ecology and epidemiology of Rocky Mountain spotted fever, and we'll follow that up with the unique situation that's been occurring in the American Southwest and northern Mexico. We'll discuss a bit the context for Rocky Mountain spotted fever vaccine development. I will share with you our practitioner survey findings, and we'll talk about the conclusions we gleaned from those survey findings. And then we'll talk a little bit about educational opportunities for veterinarians around this information and future directions going forward. A quick disclaimer here. Some of the images in this presentation demonstrate severe clinical disease in people and animals, especially children, and show people and animals in potentially distressing situations, which may be disturbing. So you'll see this symbol in the top right corner of a slide before these images are displayed so that you can avoid seeing these images if you'd like to. The intent here is not for shock value, but I do want to show you the extent and the deadly nature of this disease. All right, let's get into the clinical presentation and management of Rocky Mountain spotted fever. Rocky Mountain spotted fever, or RMSF, is a tick-borne disease caused by the bacterium Rickettsia rickettsii. Now, Rickettsia rickettsii is a member of the spotted fever group, or SFG, of rickettsial diseases that include several other rickettsial organisms that can cause disease in humans. Now, Rickettsia rickettsii can cause disease in both humans and dogs. On the left, we have an image of a child's forearm, and this child is affected by late-stage Rocky Mountain spotted fever. We can see here the black fingertips, the necrosis of the digits, as well as the necrosis of that skin in the forearm there. On the right-hand side, we have a dog who's severely affected, and this poor guy has petechial hemorrhages on his oral mucous membranes. Important to note, Rickettsia rickettsii infects endothelial cells. In fact, it reproduces inside endothelial cells, and it's cytopathic. So it causes vascular damage, and this vascular damage is responsible for the clinical disease pattern. Organs and tissues with lots of microcirculation and small vessels are most affected. We have four sections of tissue on this slide: kidney, liver, heart, and peripheral nerve. And if you squint, and look closer, you can see the purple specks in there is actually rickettsia infecting these tissues. So how does this turn out grossly on clinical presentation? Well, we have a section of skin here on the left with extravasated red blood cells, and this is from that microvascular damage from rickettsia. And this translates grossly as petechiations, which you can see in this patient on the right. Rocky Mountain spotted fever is the oldest and most lethal tick-borne rickettsial disease in humans. In fact, it's the most deadly tick-borne disease in the Western Hemisphere. Here we can see some late-stage effects in a child, including the gangrenous necrosis of those digits. It's actually rapidly fatal in people without treatment, and most deaths in people occur between 7 and 9 days after the symptom onset. There is a case fatality rate that can approach 40% in people, higher in some regions. We'll get to that a little later. But just to give you a frame of reference, what other diseases in people have a case fatality rate approaching 40%? Smallpox, for one, plague, hantavirus, and MERS virus all have similar case fatality rates. So this is a very bad disease, a deadly disease. As I said, this disease is deadly and it's unforgiving. And sadly, it disproportionately affects children because they have common contact with the tick vectors and the canine hosts that these tick vectors like to live on. It's also the deadliest tick-borne rickettsial disease of dogs, with a case fatality rate approaching 10% in dogs. We don't have great information on the seroprevalence ranges in dogs. It's not super accurate, given that cross-reactivity can occur. And that we don't really have any useful, sufficient, appropriate data on the number of dogs that are diagnosed each year in the United States. But the clinical signs do begin 3 to 7 days after inoculation via a tick bite. And you can see the engorged female tick circled on the paw of this guy here. Early presentation of RMSF in dogs can be mistaken for other diseases. And this is because the signs and symptoms can be nonspecific and can include fever, joint pain, muscle pain, and generalized lethargy or feeling unwell. Very similar presentation initially in people. Again, those signs can be mistaken for other diseases in people as well. Other nonspecific signs and symptoms in dogs can include generalized lymphadenopathy, abdominal pain, vomiting, and diarrhea. And severely affected dogs can develop petechial hemorrhages on their mucous membranes and skin, edema, especially facial edema, like this guy in the upper right-hand corner. Males can develop scrotal edema as well. They may experience epistaxis and disseminated intravascular coagulation, or DIC. Ocular hemorrhage and scleral injection are also common in affected dogs. They might also experience ataxia or altered mentation if they have encephalitis from this infection. And reports of splenomegaly and myocarditis from this disease also are present. Our clin path changes primarily result from that endothelial damage. Remember, we're having damage to these small vessels in the body, and so we can see thrombocytopenia, and this is one of the most common clin path changes. Anemia, hypoproteinemia, and hypoalbuminemia. Some dogs may experience azotemia. And elevated liver transaminases, also very common in people. Some dogs start with a little bit of a leukopenia, and as disease progresses, they become sicker and sicker. They may develop a leukocytosis. And then hyponatremia and hypocalcemia. The list of differential diagnoses for dogs can include other tick-borne diseases, depending on the tick vectors in your area. So, ehrlichiosis, Lyme disease, babesiosis, anaplasmosis. In fact, concurrent infections with multiple tick-borne diseases is not uncommon in dogs, and it may just indicate that that dog's been exposed to a brown dog tick because those ticks can carry multiple nasty diseases that can be transmitted to dogs. Leptospirosis, immune-mediated diseases, canine distemper. Other things that cause DIC or sepsis could be on the list. This is not an exhaustive list. It's just to kind of give you a general idea of which direction you might want to be thinking in. And I will say also that those symptoms of disease and other tick-borne diseases can be pretty similar, and so it can be hard to tease out which tick-borne disease you're looking at. Diagnosis in dogs is made using clinical signs, history, and most commonly serology. And for serology, we're using indirect fluorescent antibody, that's IFA. And our gold standard here is going to be that four-fold rise in titers over 2 to 4 weeks. So the dog comes in, he's sick, he's showing signs, he has a consistent history with outdoor activity where he might have been exposed to a tick carrying Rocky Mountain spotted fever. We're going to collect a sample then, and then we're going to collect another sample during that convalescent period a few weeks later. A single titer is really not sufficient to diagnose this disease, and there are a couple reasons for that. One, some dogs take a while to mount immune response, and so you may just have, if you only had one IFA, it could be negative, and you might be fooled into thinking, well, this isn't really Rocky Mountain spotted fever, I just have one negative test. Not necessarily true. And then we can also have cross-reactivity with other rickettsial species, so you really want those two titers over that 2 to 4 week period. I will also say, like, important to note here, this is actually a retrospective diagnosis, right? Because we're not totally sure in the beginning when we collect that first sample. Oops, sorry. When we collect that first sample, and so it can take a while to actually like get a definitive diagnosis on this if we're going to take a convalescent sample. You can go for PCR if you like. The best time to do that is very early or very late in the disease. The reason for this is rickettsia is just not really hanging out in the whole blood like when you're trying to take a PCR sample for a whole blood sample. So it does like to sequester into those endothelial cells and doesn't like to come out unless the dog is super sick or very early in the disease. Unfortunately, we don't have a rapid SNAP test available like we do for Ehrlichia or Anaplas in dogs. It's hard to find cases, hard to diagnose cases of RMSF when we don't have a simple, easy in-clinic test for it. You can consider IHC staining of infected tissues. This really isn't done very commonly in dogs except on postmortem. And a blood smear here is not going to be super helpful for you. Again, same reason, it's not going to be floating around in the bloodstream while you're trying to do collect sample for a blood smear, but it can help rule out other diseases. There are a good many labs that actually provide testing for dogs. This is in no particular order and is not meant to advertise for a particular laboratory, but IDEXX and Antech both offer IFA and PCR, and there are a bunch of veterinary university diagnostic labs that offer testing as well. So check out your local labs and see what they have to offer in your area. Doxycycline is the treatment of choice here. We can give it every 12 hours, we can give it every 24 hours. These rickettsial organisms are very responsive to doxycycline. So if you don't have marked improvement within a day or two, you need to be thinking about a different etiology, a non-rickettsial etiology for the dog's illness. You can give this orally or intravenously. It's usually a 2 to 3 week treatment course depending on the shape of the dog. And other than that, it's just supportive care, fluids, pain meds, antipyretics, depending on the symptoms that that dog is showing. All right, this is important. If you suspect a dog is infected with rickettsia, you don't want to wait to administer that doxycycline. Early administration can save lives, and it can prevent long-term sequela from this very dangerous, very nasty disease. And remember, we're getting that convalescent serum sample a few weeks after original presentation, and so it could take a long time for you to get those test test results back. By that time, the dog may have already passed away or become severely ill from this disease, so you don't want to wait. All right, let's tap into this traditional ecology and epidemiology of Rocky Mountain spotted fever. It was first identified in the Bitterroot Valley in western Montana in the United States, hence the Rocky Mountain moniker. And it pretty much decimated the settler population in that region in the early 1900s. But despite its very geographically specific name, it's actually widely distributed throughout North America, Mexico, Central America, and South America. The stars over the countries in this map on the left indicate countries where spotted fever group rickettsiosis has been identified in people. Again, it's part of that spotted fever group, and this is actually a set of illnesses that are nationally notifiable in people. So health departments, physicians, laboratories have to actually report these positive tests to us here at CDC, and we gather that information for outbreak and surveillance information. RMSF reporting in dogs is actually state dependent. So you want to look at your state's animal condition reporting list and see if it's on there for you. This map shows the annual incidence of spotted fever group rickettsiosis, including Rickettsia rickettsii in people in the United States in 2023. This is the last year that we have complete data on, and so this is why the map is a couple years behind. This is given in per million population, and although it's for people, it gives us a pretty good idea of what a distribution of disease would be like in dogs too. We can see here that the southeastern and central United States, where that dark purple is the primary region that people are becoming infected. Then we see Arizona stuck out there by itself in dark purple. Yeah, we'll talk a little bit about that here momentarily, but during 2019 to 2023, more than half of all reported cases in people occurred in just 5 states. Those are Alabama, Arkansas, Missouri, North Carolina, and Tennessee. We know at least 10 different species of ticks can potentially transmit Rickettsia rickettsii to people and potentially dogs. And it's really a sporadic disease in the United States, but the Rocky Mountain wood tick in the western United States and the American dog tick on the eastern side of the United States are the classical vectors for Rocky Mountain spotted fever. Now, people and dogs at risk for running into these vectors for Rocky Mountain spotted fever are those that spend time outside, so hunting, farming, hiking, outdoor jobs, those types of things. The Rocky Mountain wood tick and the American dog tick prefer wooded and grassy habitats. So a dog with a history of outdoor activity in an endemic area with consistent clinical signs should be considered for Rocky Mountain spotted fever. And remember, owners aren't always going to recall seeing a tick on their dog or a tick bite on their dog, even if they've been hiking or hunting recently, and you might not see one on exam. And if you're actually doing the physical exam on the dog, that doesn't mean that dog isn't potentially infected with Rocky Mountain spotted fever. Just to give you a little frame of reference, about a third of people with Rocky Mountain spotted fever have no memory of a tick on them or a tick bite. So it's probably less accurate for people trying to identify ticks on their dog. They don't even remember having a tick on themselves. All right, let's get here and talk about this unique epidemiology happening in American Southwest and northern Mexico. We remember that dark purple square over Arizona there on that spotted fever map. So let's figure out what's going on here. The epidemiology of RMSF in the southwestern United States and northern Mexico is different from traditional RMSF epidemiology. And the difference is due to the emergence of Rhipicephalus sanguineus, the brown dog tick, as a vector for RMSF. And this photograph shows the relative sizes of the adult brown dog tick and its nymphal stages. The brown dog tick has a large range and can live in many environments. It's as comfortable in a wooded suburban region as it is in a sparsely populated desert area. In fact, its range extends across the whole contiguous 48 United States, up into parts of Canada and Mexico as well. Brown dog ticks are unique because all life stages prefer to feed and breed on domestic dogs. And brown dog ticks can transmit Rickettsia rickettsii transovarially, meaning that each life stage can be potentially infected with the disease. There's also a higher rate of infection of these ticks versus our traditional vectors. And one of these female ticks can produce 3,000 to 5,000 eggs, and a dog can be infested with hundreds of ticks. Like this poor guy up here in the right-hand corner, he probably has more than 100 ticks just in that one ear. Brown dog ticks prefer this peri-domestic setting where there's lots of domestic dogs to latch onto and lots of homes to sequester in and around. We call this harborage, so places that these ticks feel comfortable hiding out and staying safe, where they're able to live and reproduce in this environment. You can see all the old trash, the tires, the mattress with that dog sleeping on it in this yard here. And then we have a bunch of these dogs actually laying up against the house. And if these dogs are heavily infested, they can actually literally bring these ticks to people's doorsteps. The brown dog tick is not a one-trick pony. It can also transmit Babesia, Anaplasma, and Ehrlichia to dogs, so not just Rocky Mountain spotted fever. In the United States, tribal communities of the southwestern area have been severely impacted by emerging brown dog tick associated RMSF. But why the severe emergence in these tribal lands? Well, it's because there's several epidemiological and environmental factors that are contributing to the spread of RMSF in these communities. First of all, brown dog ticks can live in a hot, dry climate, and that's what we got in the American Southwest and northern Mexico. Other tick species would shrivel up and die, but not the brown dog tick. It doesn't mind living here at all. There are large populations of free-roaming dogs in close proximity to humans in these areas. And there is a high abundance of infestations with ticks on these dogs, and this occurs year-round, no break for weather. Unfortunately, these communities experience limited access to veterinary care, waste management to remove that harborage for ticks, and vector control both on the dogs themselves and also on the in and outside the homes and in the environment. So really this is kind of a perfect storm of factors here that allow these populations of brown dog ticks to thrive. This emergence first was noted in 2003 in Arizona, where a young girl in one of these tribal communities actually died from Rocky Mountain spotted fever. And people were mystified because the traditional vectors of Rocky Mountain spotted fever don't live in this area of Arizona. And so CDC collaborated with tribal community partners, with state and local health organizations to try to figure out what was going on here. And after some investigation, they discovered that actually these brown dog ticks were the vectors carrying Rickettsia rickettsii in these communities. So the difference in this vector has been huge for these communities, causing very serious infestations, both inside and outside homes. This picture on the right here shows a whole bunch of ticks crawling up the outside of this person's house, and you can see them actually on the ground in front of the house as well here. This graph shows reported cases of RMSF in Arizona between 2003 and 2025. The blue bars are the number of cases for each year, and the orange line shows the number of deaths. You can see that the numbers of cases and deaths peaked around 2011, 2013. and then kind of tailed off after that. We, along with tribal partners and community efforts, it was actually a huge effort to actually implement some community interventions to try to knock down the number of cases and deaths in these communities. But it kind of has crept back up, and in 2018, we began partnering once again and providing technical assistance and subject matter expertise in these communities to help control the spread of this disease again. But the good news for us in Arizona here is that we haven't had any deaths reported from Rocky Mountain spotted fever since 2019. So that's great news. And as you can see, the number of cases have decreased. Now let's contrast that with what's happening in northern Mexico. Because in Arizona, in our tribal communities, we have sparsely populated communities in a desert region. But in northern Mexico, this is hitting heavily populated urban areas with large populations of free-roaming dogs. And this is a recipe for disaster here in northern Mexico. And indeed, it has become a true public health crisis there. These case fatality rates are from a few states in northern Mexico from 2022. You can see in one Mexican state that we had 69% case fatality rate. Very sad. In fact, over a 3-year period, there's been more than 500 deaths. That's between 2021 and 2023 in the states of northern Mexico. And because of what we know about this disease, we can assume that many of these deaths were in children. So I hope I've convinced you that this is a bad disease and it affects a lot of people and it affects a lot of dogs. So let's talk a little bit about a context here for vaccine development. Outbreaks of these brown dog tick associated RMSF cases have increased concerns, and there's been a push for more sustainable solutions, as you might imagine. Right now, we're using community interventions. This is really like the ultimate One Health challenge here. We have a disease where a dog is a reservoir and we have a tick vector and they're interacting closely with people. And so this takes a lot of time, a lot of effort, a lot of money to institute these interventions to try and control this disease. So we've aimed our interventions at community and healthcare provider education, vector control for the dogs and the environment, and also just overall improved animal care and wellness. We want these dogs to be healthy and well, better able to fight off illnesses, and spay and neuter is really important too, because we want to reduce the amount of dogs in the area that are potentially able to serve as reservoir hosts for this bacteria. But frustratingly, we cannot eliminate RMSF from endemic communities with the tools we currently have. And so these communities are kind of learning to live with this disease, but it shouldn't have to be that way. And there's really been an outcry recently. Really, there's some proponents that this is really an unmet need, that we need to really have a vaccine to really truly control this disease, both in dogs and people. I think Janet Foley said it best in her recent publication that anti-tick or anti-rickettsia vaccines for dogs would be an enormously beneficial strategy to reduce RMSF and could allow for reduced acaricide use, that's pesticide use, lower environmental contamination from those pesticides, reduced use of those pesticides, and potentially protection against multiple tick species. But unfortunately, no vaccine exists, neither for humans nor for dogs. And it's not for lack of trying. Despite decades of research, a vaccine has yet to attain a lasting market presence for a number of reasons. A perceived lack of interest in a vaccine from manufacturers, healthcare providers, veterinarians, pet owners. The perception that a vaccine would really only benefit a few underserved or low-income communities, or potentially that only people in these communities would really be even interested in a vaccine, that it's not applicable to the larger population in the United States. Cost, always a factor. The difficulty of production, and then the variation in species-specific responses to vaccination. So just because we have a vaccination that's working great in protecting guinea pigs or mice from Rocky Mountain spotted fever doesn't necessarily mean it's going to be a useful vaccine in dogs. But in a perfect world, wouldn't it be wonderful to have a vaccine that could protect both animal and human health, similar to what a rabies vaccine does? Administering a vaccine once or twice for lifelong immunity is much less labor intensive, time consuming, and resource dependent than having to depend on owner compliance for repeated collaring or topicals for dogs and spraying pesticides on houses. But why a canine vaccine? Why not just vaccinate people for Rocky Mountain spotted fever? I mean, it's been attempted before. Well, dogs are the primary reservoir host for brown dog tick associated Rickettsia rickettsii. And because they're the competent reservoir host, they make a perfect target for a vaccine. Humans are just the dead end host in this situation. So breaking the transmission cycle at this link in the chain can keep dogs healthy, and it can also keep humans healthy. In basic terms, there are two approaches to vaccine development for Rocky Mountain spotted fever in dogs. The first is an anti-tick vaccine. So we can create a vaccination against, for example, Rhipicephalus sanguineus, the brown dog tick, or maybe Dermacentor species ticks. And the idea here is to get at one of these proteins or subunits that are responsible for important behavior and feeding practices in the tick. So if we can reduce tick attachment to the host, tick feeding or reproduction, we can reduce the number of ticks in the environment and then reduce that disease burden in that community. Bam, we've got less cases in dogs and we've got healthier people too. The second approach is the more traditional approach that we normally think about when we're creating a vaccine, and that is to target Rickettsia rickettsii itself, the bacteria itself. Most attempts at vaccines have been in people, but I've provided here a brief summary of attempts targeted specifically for animals. The one you might be familiar with is on the left-hand side, the anti-tick approaches. The BM86 tick gut protein is actually used against Rhipicephalus microplus, a relative of Rhipicephalus sanguineus, the brown dog tick, to protect cattle from cattle tick fever. And that's been in use for 30 years or more. It's actually been on the market for quite some time, but it's not available in the United States. And so there have been a number of attempts, both from the anti-tick approach and from the anti-Rickettsia rickettsii approach. A couple of recent experiments with a killed whole soy antigen have proven efficacious in dogs. And then there's the whole concept of using a less virulent strain of a relative of Rickettsia rickettsii to kind of provide cross protection. There's been some promising work there. And then the P0 tick ribosomal unit that's proven successful in rabbits. I'm hoping to do some experiments with that in the future for dogs as well. The good news is there are lots of folks out there doing good research in this area. All right, let's get into our survey results. This is the first national survey on veterinarian receptivity to a canine RMSF vaccine, and this survey was completed in collaboration between CDC and the American Veterinary Medical Association, AVMA. We had three primary objectives for this survey. The first was determine receptivity among veterinarians. The second was to determine receptivity among clients. And then the third here was to explore possible educational needs for practitioners around Rocky Mountain spotted fever and the vaccine technology. So we included AVMA members who self-identified as either companion or mixed animal practitioners in our survey. This is because these are the folks who are working with dogs on a daily basis. The companion and mixed animal practitioners received a unique survey link from AVMA in order to participate in this survey. We ended up with 801 qualified responses, and about 91% of those respondents were companion animal practitioners, and about 9% were mixed animal practitioners. And we collected these responses between June 9th and July 1st of 2025. Our statistical analysis is a little complex here. We did some modeling, but the basics are that we've reported both the true responses from those persons who took the survey, those are our respondents, and then we use that information to generate estimates for what this would mean for the larger veterinary community of companion and mixed animal practitioners. So we collected demographic information and we used AVMA's internal member database, and also we asked questions by survey questionnaire. And we wanted to know the sex of participants, their age, their graduation year, which we also used as a proxy for practitioner experience. We split that into 3 groups based on graduation year. Those were early career, mid-career, and then we had our experienced career veterinarians. We also wanted to collect information on the type of practice environment they were working in. So whether this be suburban, urban, or a rural type environment. And then finally here, we wanted to know where they were practicing. So the state where respondents were primarily practicing in, and then their region, which we put into one of 4 regions: Southwest, Midwest, or Northeast region. And the remaining 9 questions surveyed respondents on their confidence and experience with Rocky Mountain spotted fever in dogs, their receptibility to a canine vaccine, and their client's receptibility to a canine vaccine. We also collected free text responses to provide contextual understanding. We didn't want to just get a yes, no, or unsure on these questions. We wanted to understand why these respondents were answering the way they did, and we wanted to use this information to provide insights for educational opportunities. All right, so the demographic characteristics of our survey respondents included about 75% female respondents, most in the 50 to 59-year-old age group, who were experienced grads, practicing in a suburban region primarily, and most respondents were from the southern region of the United States. We found that over half, that's 59% of respondents, reported never having diagnosed a case of confirmed or presumptive RMSF in a dog. And so based on this response, we estimate that about 62% of mixed and companion animal practitioners have never diagnosed a case. We also estimated that practitioners who had previously diagnosed a case would be more likely to recommend a vaccine. You can see that here in this table where we have folks interested in recommending a vaccine in the columns, and whether they had diagnosed a case in the rows. You look at the intersection of those yeses and you see that we have 34% of those respondents who had both diagnosed a case and were willing to recommend a vaccine, versus only 24% who had not diagnosed a case. We estimated that about 39% of practitioners, regardless of whether they had seen a case, were unsure about recommending a vaccine. Now, we don't want to sleep on these unsure responses, because in my mind, these are practitioners that, given the right information, could improve their patient outcomes and potentially be more willing to be receptive about a vaccine. We collected these free text responses for practitioners because we wanted to figure out why practitioners were unsure about recommending a vaccine, since we had so many unsure responses. We found that many practitioners were unsure or said they needed more information about this vaccine technology and safety. In other words, they just didn't understand what an anti-tick vaccine would look like, or potentially what an anti-rickettsia vaccine would look like. Would it be safe for use in their practice? They just wanted more information. Some practitioners said, well, it's not endemic in my area. I don't see any cases reported, so I'm not interested in a vaccine. Not really, because it doesn't seem to be a problem in my region. Concerns for cost, always at the top. And then the concern here for not wanting to push another vaccine to clients. And we know that vaccine hesitancy in veterinary medicine is a real thing now. And it's hard enough to get some folks to be accepting a rabies vaccine, much less a vaccine for a disease they've never heard of, like Rocky Mountain spotted fever. So, understandable apprehension there. We did find a positive relationship between practitioner confidence in identifying clinical signs and practitioner interest in recommending a vaccine to clients. Let's take a look at that here. We found that the odds of recommending a vaccine was 3.9 times greater in practitioners who were very confident in identifying symptoms versus those who were not confident at all. You can see here on the y-axis, we've got our confidence levels, and then on the bottom we have our odds ratios here, and then the blue lines are yes, and the orange lines here are unsure about vaccinating. And you can see that purple star over the 3.9 times greater odds. We also found that early career grads were more likely to recommend a vaccine than mid and experienced grads, who are more likely to be unsure about recommending a vaccine. This graph compares practitioner experience level on the y-axis with willingness to recommend a vaccine on the x-axis in percents. Yes is indicated by blue, no is gray, and unsure is orange here. And we can see up here those early career grads more willing to recommend a vaccine versus those in the mid and experienced career categories who are just more likely to be unsure over there in the orange. We found that interest in a vaccine was not limited to a specific region or practice environment. This graph compares the U.S. practice region on the y-axis with a willingness to recommend a vaccine. You can see those yes responses in blue, and they are spread over those various regions there. And you can see that percent willingness to recommend a vaccine on the x-axis there. This graph compares practice environment and willingness to recommend a vaccine. You can see here that we have interest across urban, suburban, and rural practice environments, with persons in an urban practice environment more likely to recommend a vaccine. We also asked practitioners if they thought their clients would be interested in an RMSF vaccine for their dogs. Important question, right? It's one thing to have receptibility to vaccine in the veterinarians, but how about the clients? They're the ones who are really the ones who are purchasing that product in the long run for the health of their dogs. So we found that 53% of respondents, or about estimated 54% of practitioners overall, said their clients would be interested in a vaccine for their dogs. So that's over half of these practitioners' clients being interested in a potential vaccine for their dogs. Now, importantly, most of these folks were interested in a combination Lyme vaccine with Rocky Mountain spotted fever. So in this way, you've got a tick vaccine that's sort of a double whammy. You've got the Lyme disease vaccine in there, and then you've got potentially the Rocky Mountain spotted fever vaccine in there. And this is a nice compromise for those who are worried about pushing another vaccine to clients. You've got this this extra cost benefit factor in here for having both of these in one product. We also asked practitioners if an anti-tick combo vaccine was available that produces an antibody response not only to the brown dog tick, but also antibodies to other tick species like Dermacentor or Ixodes. Would you be more likely to use this vaccine in your practice? And a resounding 78% of practitioners were interested in a combination anti-tick vaccine for their practice. And this is essentially reflective of the fact that veterinarians are very interested in utilizing a vaccine in their practice that protects their patients from multiple tick-borne diseases. So, what have we concluded from all this information, and what do we do? What are our future directions with this information? I think it's important to address again why we had so many unsure and no responses in this survey. And really, the main theme here is these educational gaps. Gaps in identifying Rocky Mountain spotted fever, being comfortable diagnosing a case, awareness of vectors in a practitioner's area, and being unsure or unfamiliar with the vaccine technology. All things we can remedy through education. The second thing here is we don't have a dependable, easy in-clinic testing modality like we do for anaplasmosis or Lyme disease. And so it makes it tough, right? You can't find cases of Rocky Mountain spotted fever if you don't have a test for it, right? So, this is potentially a situation where Rocky Mountain spotted fever is present, but we don't have a specific test for it in clinic, not showing up on a SNAP test, right? It's not there on a SNAP test. And so maybe it is in that area, but folks just aren't diagnosing it. Cost, always a concern. This idea of the cost benefit of carrying an additional vaccine in a practice. And then finally, once again, this vaccine hesitancy that practitioners are experiencing with clients just not being interested in even the most simple of vaccines like a rabies vaccine. So tough to push another vaccine, totally understandable. But increasing knowledge and comfort with Rocky Mountain spotted fever case management might improve practitioner willingness to recommend a vaccine and also improve patient outcomes here because we're not just looking to push a vaccine to people. Now, that's important for both human and animal health, but we also want to improve patient outcomes. So for missing diagnoses of Rocky Mountain spotted fever, and we could be doing better by actually finding these cases, that could really improve the health of our patients. Despite the educational gaps that we identified, there is market interest in a vaccine across regions in the United States. Kind of refutes the notion that only a few select regions or people in certain hyperendemic areas would be even interested in a vaccine. And more than half of practitioners believe that their clients would be interested in a vaccine, so there's a market available here. And we know that it seems like the best way to do this would be in a combination with an existing Lyme disease vaccine, for example. We know that 78% of practitioners were interested in a more general anti-tick vaccine, which included not only brown dog tick, but also protection against dermacentor and ixodes. And again, this is reflective of the interest of practitioners to really protect their patients against multiple tick-borne diseases. So great cost to benefit ratio here with a multi anti-tick vaccine. So future directions. We're at the end here, and we know we still have work to do. Increasing awareness for this critical need for a canine vaccine to protect both human and animal health is very important. We want to continue educating veterinarians and the public about Rocky Mountain spotted fever. And we want to continue to work with vaccine developers, provide information, and advise on the most effective way to deliver a Rocky Mountain spotted fever vaccine to the market that's going to sustain a lasting presence. I appreciate your time and attention this evening away from your family and friends. I will be very happy to take any questions that you have. If you'd like to reach out to our inbox, it's rzbepidiag@cdc.gov. And then if you just have specific questions you want to ask me, my email's up here as well. Always happy to lend a hand anytime we can. We're here to help. So with that, I will turn back over to Eric and crew for question time.
Okay, we do have a few questions here that we'd like to go ahead and present to Dr. Moore.
Okay.
You focused on the rural portions of Arizona and the
Mhm,
incidence of RMSF there,
mhm.
are, are there incidents of the disease in more developed parts of Arizona?
I'm sure there are. I don't have specific data on reports outside of those endemic communities because the traditional vectors just aren't really present in areas outside there. So we're not getting like super sporadic cases throughout Arizona. It's really concentrated in those communities.
And then that kind of follows up another question with regarding to flea and tick topical treatments. I mean, have there been any, uh, uh, I guess, studies or any attempts at, um, distributing flea and tick control products that would be effective in not only, decreasing the tick population, but effective at preventing RMSF in the community?
We do that. It's a part of our community interventions in these hyperendemic regions. We literally go out to these tribal communities in Arizona and we provide subject matter expertise and technical assistance. We literally go door to door in these communities and we put collars on dogs and we put topicals on puppies and we spray houses and we educate folks about Rocky Mountain spotted fever in these communities. And they do receive some products from these manufacturers at a discounted rate. So they're actually able to afford more. And then they actually receive federal grant money as well. And so they're able to use some of that money to put towards tick prevention in their communities.
Can you comment on how COVID-19 pandemic and access to healthcare may have impacted the fatality rate in northern Mexico?
Yeah, I think a lot of the folks who are severely affected by this disease in general, just in those regions in general, just don't have easy access to healthcare. They live in an area where they don't have transportation. It's not easier for them to get healthcare. Um, and the rapid progression of this disease, like by the time they've waited a few days and ended up in the hospital, for a lot of these folks, it's too late, and it's already a tragic end for them. I think people were afraid to go out of the house. We saw this with a lot of different diseases, like sexually transmitted infections, other respiratory diseases during that COVID-19 period, where folks just didn't want to go to the doctor at all. They were worried about that, and so yeah, I think it has probably had an effect.
Uh, Next question is in states with RMSF in dogs where it is reportable, are dogs cases useful as sentinels for cases in humans?
Um, I think potentially, definitely, just like we do with like Lyme disease and other tick-borne diseases and mosquito-borne diseases as well. I think the funny thing here is since the it's not reportable in all states for dogs. We don't have the clearest picture of like where this disease is like really bad for dogs and where these cases are occurring. So I think in some way, like since we have more complete data for people, we're kind of using people as the sentinels for dogs in a weird way because we have more complete data because it's nationally notifiable in people. And we can assume since the vectors are the same that dogs in those regions are being exposed to like the same vectors as the people are. So there's overlap there.
Okay. With regard to your study, you focused on U.S. veterinarians. I
Uh-huh.
mean, has there been any correspondence or any indication regarding interest among those our colleagues in Mexico, Central America?
Yeah, if you haven't read that paper by David Walker on the unmet need for a vaccine, that talks a lot about the need for vaccination and some more substantial prevention methodology in northern Mexico. We are in communication with partners in Mexico. There's not like a whole lot. We do collaborate with them, but it's like we don't we don't have jurisdiction there. So really, what we have is like available to us is United States practitioners. We don't have any survey data of practitioners in Mexico.
Uh, Kind of going back to the disease itself, can there be RMSF seropositive dogs that do not develop any clinical signs?
Yeah, so sometimes the signs can be mild or not noticed, or the dog could potentially seroconvert and not show any signs. That does happen.
Okay.
But we don't have super great data on seroprevalence in dogs. Like it ranges anywhere from like 4% to like 77%, depending on what population of dogs you're looking at. Now, in these hyperendemic communities, you're going to find a lot of seropositive dogs. But they're not all walking around sick and sad looking, right? From Rocky Mountain spotted fever, they have like fought off that disease. Puppies are usually the ones that get super sick from it because they don't have any like developed immunity to it, and they kind of form a little bit better immunity over time as adult dogs.
A couple questions regarding vaccines and other, I guess, injectables. You have any comments about the long-lasting anti-parasitic injectables on the market now, and whether these are also being considered studied for use in control and prevention of RMSF?
Yeah, we've actually had some discussions about that with our tribal partners. The major prohibitive issue there is the cost of that product. Um, and the fact that, we are still going to have to give it, and depend on owner compliance for that. But we have had discussions about that. I think it can change the game and certainly in some specific situations in these hyperendemic communities, and even in places where it's not super hyperendemic. It's great if like an owner is just willing to have one of these long-acting injections, and then they don't have to worry about putting a flea collar on or a topical on every few months or monthly. That's part of like the big issue that we have here in controlling this disease is because God, these ticks are just, these brown dog ticks are so aggressive and they cause such heavy, heavy infestations. And even some of these collars that are labeled for like 8 months of coverage against brown dog ticks don't even last that long in this area. And then, gosh, the environments were super tough on those collars too. Very hot, very dry. And so they tend to be a little less efficacious. But a way around that potentially is to use the injectable product. The issue there is again, like we have to have an accurate weight on the dog. We don't carry around a scale for dogs out in the field to try and weigh them. They are so like semi-feral that you couldn't pick them up and weigh them anyways. And so the dogs who would really most benefit from that would be like the dogs that are in people's houses and they're more like owned than like community dogs, more feral dogs. So I think there is an application for that, but I'm not so sure that widespread use in a hyper-endemic community, given the cost and difficulty of administering that product, is totally feasible.
You mentioned feral dogs. I would assume that the wildlife in those areas it's pretty much endemic in the wild canine
Yeah,
population.
so yeah, dogs aren't the only potential reservoir, so it can be around there and other animals, but really like you'll be in a community and you'll say there'll be like 5 dogs in a yard. And you'll ask somebody like, "Are these your dogs?" And they'll say, "No, no, they're not my dogs, but I just feed them." And they just kind of hang out in the yard. So there's no really like specific responsibility in some of these scenarios for taking care of these dogs that are kind of just like feral and roam around. And folks don't necessarily want to take like specific responsibility for the dogs that are like hanging around their house. And you can understand that. I mean, we're talking about like tens of thousands of just feral roaming dogs in some of these communities. So. And they sometimes come down from the mountains at night and feed on the garbage, and ticks run off of them into people's houses, and they're less apparent during the day until they come back again for another meal. But it's a very difficult situation in these communities.
Okay. Um, Are you aware of any work that's being done around tick attachment vaccines? You had mentioned a, a tick attachment oriented vaccine for cattle not licensed here in the US.
Yeah.
But do you foresee any technology being brought to the US for that purpose?
I hope so. There's a promising study with the BM86 tick gut protein, actually in. And so I'm hoping that technology is going to be leveraged in a vaccine for Rhipicephalus sanguineus at the least. But we know it works in our microplus, so there's a potential there to like for using that for actually multiple tick species, which is pretty exciting.
And then finally, we'll close out with this question about as the CDC, or are you aware of any partnerships with other large diagnostic companies or corporate veterinary practices to assess testing and RMSF diagnosis in dogs?
I can't speak specifically about that because we don't have like specific contracts with certain corporate partners, unfortunately. We do occasionally work with corporate labs on obtaining like samples for like serosurveys and things like that, but we don't have like um, a direct partnership pipeline into the canine information, unfortunately. I think that would be an interesting study to do to like really look at seroprevalence using testing from the big labs that do most of the testing, and we can kind of see like does it really overlap with human case. I think that'd be very interesting information to have, considering we don't really have a national survey of that. It's all kind of pieces, parts, serosurveys from different regions.
Okay. Well, I want to thank the attendees for attending, for you know participating in today's webinar. I particularly want to thank Dr. Moore. Dr. Moore is one of our repeat presenters, and this presentation was just as good, if not better, than the last one. I'm sure you're seeing it, you're getting a lot of clapping hands, hearts, and everything else floating up on the Zoom screen here. So our participants definitely appreciate your time and effort in presenting this topic to us. As Dr. Sringanathan said at the beginning, we can't do this without volunteers like Dr. Moore. So we ask that if anybody is interested in making a presentation such as this on any topic that somewhat related to veterinary preventive medicine or veterinary medicine as a whole, you can do so by emailing us. You can email me at admin@acvpm.org. There's also a portal on the ACVPM webpage for continuing education that you can nominate someone as a speaker. And we'll get that to our continuing education committee, and they can evaluate the topic and hopefully put you on the schedule. So again, if you're considering making a present, or if you give a presentation someplace, we'd appreciate considering giving it to us also as part of our CE program. Our next webinar has been announced, the 19th of May, and so keep an eye out for that invitation. It went out a couple days ago. So with that, I want to thank Dr. Moore once again. I want to thank the attendees, and everybody have a wonderful evening and a great rest of your week. Thank you very much.
Okay, thank you guys so much. I appreciate you. Have a good evening, everyone.